We're taking it a little bit sooner. So I like this. This comes from a calendar I bought from one of my friends. She's making things on Zazzle, and so I ordered one of her calendars. And it says this is going to be an amazing year because not only will I start strong, but I will also end strong. So I'm hoping that all of you will end strong and take your NCLEX and pass because a lot of things are changing. It doesn't necessarily mean it's going to get harder, but we know with changes, it does take some getting used to. It does take a lot of adapting to what we've been studying. So with anything, there comes change and adaptation along with it. Right. So health promotion. This is what we're on tonight. Um, Health promotion and maintenance. What you're tested on in this category is what it says up at the top. The nurse includes or provides and directs nursing care of the client and incorporates knowledge of expected growth and development. So, not one of my favorite topics, but we're going through all the life stages: the newborn, the infant, the toddler, preschooler, school age, the adults, and then the elderly or geriatric patients. Prevention and early detection of health problems, and we have to be able to know like risk factors, and be able to recognize when a patient is at risk for developing a complication or what things can impede them from staying healthy or promoting their health. All right, and then we're also learning strategies to achieve optimal health. So we're tested on all those things, including our maternity clients, antepartum, postpartum, intrapartum. It's a lot of teaching in health promotion, planning and participating in community health education, targeting screening assessments, vision and nutrition. So all those different screenings. A good section to look at if you're using the Saunders review is the health assessments. All right, and then educate client about prevention and treatment of high risk health behaviors, and performing those comprehensive health assessments and managing care in the home environment and planning for them, especially risk factors, risk for falls and things like that. So health promotion is 9% plus or minus 3, 9% of the exam. And we only have one more category to go. So we're doing psychosocial. I can't believe it's been 8 weeks. We went through all 8. After next week, we'll do psychosocial next Sunday. All right, so that was the NCLEX PN or NCLEX RN. For the NCLEX PN, pretty much tested on the same thing: knowledge of expected stages of growth and development, and prevention and or the early detection of health problems. So most of this that's on here is pretty much the same information. And this category is actually about the same percentage as well. Health promotion is 9%. All right. So after the last one, yeah, I think we will do probably one more testing strategies. That would be a good topic to go over. Maybe testing strategies. And I was thinking about doing one on SATA. Yep, I think SATA would be good. And also prioritization. A lot of the last couple clients that took theirs and passed, they said they got a lot of prioritization. So that's big on NCLEX as well. Yeah, that's a very good idea. All right, so our outline for tonight, we're going to be looking at postpartum bleeding priority, a little bit of prioritizing a child's assessment, preeclampsia, toddler, and some nursing interventions, and we'll see what's going on with that patient. Got a lot of patients. Maintaining health and some risk factors and healing. So on the NCLEX exam, health promotion is going to involve helping your clients achieve and continue to enjoy their optimal health. You're helping people to identify that target state. Where are we trying to achieve? What's our goal? You're discovering their strengths, their needs, and then you're going to support their path to full health and wellness potential. All right, here's our first question. So it's a lot of stuff going on. This is our postpartum client. So I want you to read through it and think about what testing strategy you can use, because I feel like a lot of us, we underuse our testing strategies. So think about what you can use to help guide you to the correct answer. Use your process of elimination. Look at your case event. Think about what's going on with this patient and pay attention to those little details. All right. So this postpartum patient, we're getting report. The nurse is getting report about a client, and they had vaginal delivery the night before. All right. So I was assuming this is day shift, but I don't know because it just says the night before. So I don't know if this is morning, daytime. Um, but the client has been passing golf ball size clots. Okay, so that's one. Change this to we'll do purple. All right, and so that was on her period pad for the last few hours. She delivered the night before. All right, a lot of people are saying D. We got D. Good. I like D. Awesome. Her blood pressure is low. Her heart rate is up. And this was key, is that the nurse enters the client's room and she's also bleeding. Blood is oozing from her IV site. So she has a lot going on. She's got this signs and symptoms of hypovolemia, low blood pressure. She's tachycardic to compensate, and she's got these golf ball size clots, and she's already delivered the night before. So we know immediately post-op we should have already palpated and massaged her uterus. Her uterus should be firm by now, should have firmed up, and should be that should have been something we would have done within that first 24 hours. All right. So, yeah, very good. A lot of you, if you chose D, that is correct. So, this is a priority question. Which action should the nurse take first? If you were thinking palpating, then we're kind of out of that time proximity for palpation, because she delivered the night before, and there's been several hours that have gone on, and then she has these golf ball size clots. This is a lot happening. She's already symptomatic, blood pressure is low, and you might have seen questions like this that was saying um, the um, let's see, what was it? Oh, I think it was saying that the patient had delivered, maybe a few hours had passed, and then she was having a low blood pressure. We were suspecting she's bleeding, but we haven't massaged her uterus yet.
Yes.
Right. So let me see if give me 1 second. I just want to send this out. Okay. I was trying to send the meeting code. The first round I sent it, I think it didn't have the code on there. So I'm just gonna reply. Okay, should be working. Okay. All right. So we're out of that time proximity to palpate and massage the uterus. Performing peri-care and changing the client's peri pad, that won't really help her, because we're looking for an action, a nursing action that is going to fix this problem and or help the patient. And is it a medical emergency? So that's what you really had to recognize. Can I handle this on my own and then go back and reassess? Or is this patient past that point and I just need to notify the physician? So is it a medical emergency? So this has now become a medical emergency. This is probably a change in her condition. She seems like she's getting worse, even though we don't have a trend. But now you notice that the blood is oozing from her IV site. So she's constantly having this bleeding issue, not just vaginal bleeding, but she's bleeding now through her IV sites. So palpating won't help. This won't at least fix the oozing from her IV site. Why is she having all this bleeding? So a couple of things that would lead you to not choose B. A wasn't going to help. Breastfeeding does promote uterine contraction, but it won't help her for this situation. This is something we need to contact the provider for. So very good. Postpartum hemorrhage, there's a lot that can happen with this. This is an alteration in perfusion. So they talk about the 4 T's here. We're going to observe for clotting. We're going to check coagulation studies. And if you remember a condition called DIC, this is common, or not really common, but it can happen more commonly in maternity patients where they are clotting, clotting, clotting. They use up their clotting factors because they had to try to stop bleeding after having the baby. And then they have used up so much clotting factors that they start bleeding a lot. And it's harder for them to clot. So prepare to administer platelets, FFP. Platelets will help replace platelets if she's low on those, and FFP will help um, increase her coagulation time. So that, or I guess decrease it. So her INR is lower because probably by this time their INR is probably high, which means it takes them longer to stop bleeding. All right. Sometimes they can be bleeding from retained placenta, tears or lacerations, or a uterus that's very boggy. She may need oxytocin at this point, so we really need to contact the doctor. Hemorrhaging is going to be an estimated blood loss greater than 500, brisk bleeding, high pulse, low blood pressure. All right, so those are the things we're looking for. So this will require medical intervention only if bleeding does not stop. And for her, it just sounds like it's not stopping. It's not getting any better. So she was probably going into shock as well as DIC. Perfusion and shock are similar to the medical surgical concepts of perfusion and shock. Same thing when you're dealing with your maternity patients. Differences are in relation to the system specific assessment that's unique to the maternity patient. Just, the only difference is she's had a baby. All right. In Saunders, they do mention some priority nursing actions if you have a postpartum client who is hemorrhaging and showing signs of shock. We're going to notify the OB, the obstetrician. So that was number one. That's pretty true to the first step. Get the doctor on board, stay with the patient, maybe get another nurse to contact the doctor. If we could check the uterus during that time, massaging is not a bad idea, but it may not help for her because she was already low, hypotensive, tachycardic. She's oozing through her IV site. That was a key sign. Otherwise, I probably would have chose to check the uterus first. But then her time frame, she delivered the night before. All right, and then we can always do our shock positions. Legs are up. Get them on some oxygen. Check the vitals. Empty bladder by catheter if prescribed. We may have to insert a catheter. And she may go on oxytocin or some prostaglandins that will increase her uterine tone. Get her IV fluids going. She may need some blood products. Okay, prepare for possible surgery. If she had placenta fragments still in, they may have to do other emergency treatments for that. Right. And then another thing so that was bleeding. Another perfusion issue with postpartum is DVT. So these patients are at risk for developing a DVT. Immobility, if they've had a C-section, if they've had a previous clot, or if they were diabetic, that would put them at risk. Okay, so Doppler ultrasound scanner, we would do a Doppler to verify does she have a DVT, and they could do an MRI or CT. Usually Doppler if we're thinking of clots in the extremity. Okay, and then PE is another thing that they can develop. So same thing for our med-surg patients that can happen with our maternity clients. So we would just need to know the risk factors and the signs and symptoms. Her pulse, respiration's up, blood pressure might start dropping. She might start becoming dyspneic and hypoxic and having crackles in her lungs. Okay, all right, I'm gonna go back in just a minute. Okay, all right, let me make sure my screen is sharing. Okay, good. All right, so some notes and takeaways from this topic. All right, if you didn't get to D, answer D, then this is where I would make my notes on things to remember. The main thing with that was time, proximity, and her signs and symptoms. And the fact that they mentioned she was oozing from her IV site, that was more than just probably more than just the uterus. It's also she had signs and symptoms of going into DIC. And DIC is disseminated intravascular coagulation. It can occur after an injury. A lot of our septic patients used to go into DIC, and it can occur also after childbirth. All right, so she had a normal spontaneous vaginal delivery, and it is normal to have some bleeding on their peripad. Postpartum hemorrhage, again, it's going to be equal to or greater than 500 milliliters after birth. Her peripad, if it's saturating more than one in an hour, they're passing large clots. That's the key that this is a little more than our normal, right? Because you might see some small clots, but that was another key word, large golf ball. I think it said golf ball size clots. So that could mean she's experiencing postpartum hemorrhage, and that is an emergency. So medical emergency, contact your doctor. All right, so then they explain a little bit about DIC. Proteins in the blood form clots. The clots can travel to the injury site to help stop bleeding. If those proteins become abnormally overactive and they just keep clotting, 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 then the body can go into DIC and they eventually start bleeding out. And they can bleed out from every orifice. You know, if there's a IV or puncture site, they'll bleed out of there. All right. Those small clots can clog vessels and cut off normal blood supply to the organs. All right. So severe bleeding is a sign of DIC, oozing from puncture sites. Her pressure was low. She was tachycardic. Sometimes they'll say they're dizzy, and we'll check their pulse ox, and that's low. All right. So in this scenario, this was a medical emergency. So we would first notify the healthcare provider. All right, very good. You guys did good on that. This is just a little pathway about DIC. The only thing to take away from that is the patient, there's an injury to the tissue or injury in the body, either sepsis or the patient went through, delivering a baby, and there's a abnormal use of clotting factors and platelets. And that can cause some ischemic tissue damage because everything, there's all these micro clots that happens. And then those clots started breaking down. The body will start breaking down those blood clots, or they've also used up a lot of their clotting factors. And now it starts to take them longer to bleed, or longer to stop bleeding.